Welcome, everyone. Welcome to the Global Frailty Network Frailty Seminar Series. My name is Olga Theu. I am a researcher based in Halifax, Nova Scotia in Canada. Our speaker for today's seminar is Dr. Huisingh-Scheetz, who will present on expanding frailty assessment and management in clinical practice. But before introducing our speaker, I would like to please ask you to use the WebEx chat button when asking questions to the speaker. And for me, it's on my bottom right side, but it might be different for your screens. And we'll go through these questions at the end of our session. So now let me introduce you Dr. Huisingh-Scheetz. Dr. Megan Huisingh-Scheetz is an associate professor in the Department of Medicine in Geriatrics and Palliative Medicine at the University of Chicago. She serves as the co-director of the Successful Aging and Frailty Evaluation Clinic and associate director of the Aging Research Program with dual board certification in internal medicine and geriatrics. Dr. Huisingh-Scheetz is a nationally recognized expert in frailty, aging, and innovative technologies to enhance care for older adults. She graduated from the University of Illinois at Chicago College of Medicine, and she earned her Master's of Public Health and Epidemiology while completing her residency and fellowship training at the University of Chicago. Her research focuses on frailty assessment, physical activity, and leveraging technologies like accelerometry and voice-activated devices to improve outcomes in older adults. She has secured over 10 million in grant funding as a principal or co-investigator, leading several projects like the ENGAGE trial, which uses voice-activated technology to promote mobility and reduce disparities among undeserved communities. Dr. Huisingh-Scheetz is a prolific scholar with over 50 peer-reviewed publications, numerous invited presentations, and significant contributions to guidelines on frailty and aging. She has received multiple awards, including the Terry Fox Rising Star Award from the American Federation for Aging Research and the AGS Artie Hurrier Memorial Award for Imaging Investigators. Her leadership extends to professional societies, serving on committees for the American Geriatric Society and Gerontological Society of America. In addition to her clinical and research accomplishments, Dr. Huisingh-Scheetz is a dedicated mentor recognized for fostering the next generation of leaders in aging research. Through her innovative approaches and unwavering commitment, she continues to redefine aging care and inspired achievements in geriatric medicine. On this note, I'll hand now the presentation over to Dr. Megan Huisingh-Scheetz.
I'm really honored and humbled to be here today. I am looking forward to getting feedback from this very experienced group on my own work and future directions. So as Olga mentioned, I'll be talking about expanding frailty assessment and management in clinical practice, and I will talk about progress in this space in actual real-life clinical care, and also how I'm using research to think about the future. I don't want to forget that I'm a representative of a lot of collaborations I've had, so I'll just mention that up front. And I wanted to also be sure to include my disclosures, the most important of which is that one of the technologies that we created in our trial has intellectual property associated with it. We have not made any money off of it. We plan not to make any money off of it, but there is some intellectual property. So I'll start with the big picture view of frailty integration into geriatrics care, how we've been able to do that at the University of Chicago and align with other institutions who have been doing this as well. Then I will transition to some of the implementation scientific gaps that we have experienced and how these have informed some of the questions that I've been pursuing in my research. I will spend time talking about my two big domains of research. One is the use of technology to improve our screening and monitoring frailty over time, and then the use of technology to improve our frailty management. So I am certain that everyone in this group would agree that one of the best things about being in aging research and aging care is the wonderful heterogeneity that we experience with older adults. And one of the, while I don't want to debate here the different definitions of frailty or the specific types of frailty measurement, the way that I think about frailty is its ability to differentiate this wide variety of physiologic heterogeneity that our older adults experience. We can still see this heterogeneity manifest in life expectancy specifically. This is unfortunately data from the United States, in which we have a very, very wide gap of lifespan expectation among our racial ethnic subgroups. You can also see this heterogeneity in health looking at some of the functional measures. This is data that we published using 2 national US cohort studies in which we created what I like to call my aging growth charts. And we simply published the distribution of performance across 3 different physical function measures: usual, gait, balance, static balance, and time to perform 5 repeated chair stands. And you can see even among older adults who are in the 80s to early 80s, there's a certain percentage of people who are performing as well or better than people in their 30s and 40s. And yet we have this great 10% of folks who can't even do these tasks. So this distribution is what I'm referring to when I speak of the physiologic heterogeneity. In the clinical setting, we are currently restricted to using clinical tools to detect frailty. And I don't need to explain these measures to anyone on the call, I'm certain. But as we know from the literature, these are surrogates for underlying physiologic deterioration and biomarkers that we don't yet have available to us in the clinical setting. When we assess frailty in our current clinical practice, I will share with you how we have been using the frailty assessment itself to shape our care planning based on the literature. One way in which we use a frailty assessment is as a geriatric syndrome itself. There is literature enough to support that we can at least attempt to reverse or change the clinical manifestations of the frailty syndrome. We also have probably the most evidence to using a frailty assessment tool to aid in our risk stratification for various outcomes. And finally, we use the frailty status to shape our overall care plan, as we have evidence that multidisciplinary planning itself improves frailty over time. So in 2012, now, my goodness, it's getting a long time ago, we started a geriatric consult clinic that we call the Successful Aging and Frailty Evaluation Clinic. This is not unlike other geriatric consult clinic models, the difference being that we embedded the frailty phenotype into our comprehensive geriatric assessment. So every patient that is referred to us gets a complete standardized geriatric assessment, and then we periodically monitor their progress over time. This is a brief snapshot of the tools that we currently use. This has been a work in progress. We had much longer assessment lasting about 2 hours, and people started to get too tired, so we had to pare it back to an hour and a half. But you'll see that we have as many possible evidence-based tools across these different domains, standardized across all providers that provide care. So this is an example of an assessment plan that we might offer someone who is referred to our Successful Aging and Frailty Evaluation Clinic, in which we treat the frailty status itself as a syndrome. We will identify frailty or pre-frailty on their problem list. We will try to identify interventions that help address the presence of inactivity, the presence of weakness or slow gait, the presence of weight loss, exhaustion, and specific interventions to prepare someone for a planned intervention or procedure. We also spend time identifying and reversing other medical issues that might precipitate or accelerate the frailty course, things that we know from the literature, for example, polypharmacy, impaired sleep, uncontrolled multimorbidity, cognitive impairment or mood issues, and sensory function. And finally, we also work to reduce the higher risk outcomes that patients may face and try to prevent them. For example, avoiding motor vehicle accidents, hopefully reducing the risk of falls. We try to anticipate new social and support needs that they might have for developing disability, and certainly we spend a lot of time doing advanced care planning. The second way that we use the frailty status is to help us with our risk stratification. Some of our biggest referrals are from patients facing procedures. So we use several tools that allow us to incorporate their frailty status into our risk interpretation for the referring provider. I will point out here that this is based on literature that has used frailty status as a single measurement in one point in time. So we're incorporating their current active frailty status, but we don't have much guidance on how to interpret frailty trajectories over time into their risk. Finally, we use their frailty status to help frame their overall care plan, very much like other geriatricians who tailor care plans based on vulnerability. We use the frailty status to help us justify or quantify this vulnerability and then select interventions across other domains of their health that we think that they would benefit from, or that might no longer benefit them. For example, interventions that have a longer time to benefit. So through the last 13-ish years of doing this clinical care, there are pretty obvious implementation and scientific challenges that we have faced. Some of these we've tried to address, which are indicated by the single asterisk, and then there are others that are still ongoing challenges in which I'm trying to address with some of my research. The administration variability in these exam or these clinical measurements was a major problem early on. Subtle differences in the timing of the gait speed or how an individual would hold a dynamometer really led to changes and differences in the assessments. So we needed to standardize that. We have no and continue to have no real system-based triggers to screen referrals or to trigger referrals to us. The lengthy in-person assessments have grossly limited our provider adoption of these clinical tools in their practice. We've had some luck with shorter screening tools. We've also found that these in-person assessments have also greatly limited our ability to reach folks who are homebound or rural dwelling, as it relies on an individual coming into the clinic to be able to perform all the tests. As I mentioned earlier, we have no mechanism in the literature yet to understand how the trajectories themselves are influencing or should influence our risk assessment or even our management decisions. We struggle a lot with putting together comprehensive long-term care programming for frail adults. Most of the opportunities we have are short-term, and I'll talk more about that. This is also complicated by a discordant communication between hospital-based systems and many of our community programming for aging. And as I mentioned earlier, we have no physiologic testing, which I think is a major gap in an area ripe for research. So one of the ways that we overcame the heterogeneity in the administration of these tools was to standardize how we did this. We constructed electronic medical record tools, which guided people through each assessment and provided tips on how to administer it. We also created a training video with pictures and examples of how to administer the tools, not unlike the NIH toolbox, although the NIH toolbox specifically have the frailty phenotype in it. And then we leverage a lot of tip sheets and dot phrases to help draw in the measurements into our clinical notes. And that's been a huge help in how we administer those tests. As far as triggering referrals, the literature has given us a few guides to use. One more recent trigger has been that we have the 4M Care for Older Adults. This guide suggests that everyone should have an assessment of mobility, mentation, medications, and what matters most at every single encounter. This was recently adopted by our major payer system, the Medicare system. So this push to, or this incentive now to get mobility assessed at all encounters might be a reason to trigger more frailty screening. We also have a number of expert recommendations and guidelines. I'm sure many of you have participated in those writings that say people should be screened at certain ages, or people who have experienced weight loss. And we also have a subset of groups who have written guidelines specific to conditions or procedures. For example, the American Geriatric Society includes a frailty assessment as part of their fall evaluation. The American Geriatric Society and American College of Surgeons have recommended frailty assessment as part of their elective procedure workup and preparation. We also have similar guidelines in diabetes care, cancer treatment care, and valvular disease care. So these have been helpful guidelines in the literature, but implementing this is a little bit different. So in our experience right now, we have a huge number of primary care provider referrals. This is coming without systematic triggers, and our experience is that people are coming to us very, very, very late in the frailty course, and there's high between provider referral variability. We also have a second subgroup of referrals, and this is our procedural providers. These have often been triggered because of the elective procedure. And so we identify these folks really early on. There's a lot of consistency among the providers and when they refer patients. And so this is almost the opposite part. There's lots of consistency and they're very, very early. Some of them maybe even too early to benefit from our care. And then finally, we have tried to pilot this in some subgroups of our inpatient provider status. For example, we have a frailty screening tool in our burn ICU, which triggers consultation for geriatrics, and we're on an automatic consultation for anyone admitted for hip fracture. So I think this has been very helpful for triggering the kinds of referrals that are likely to benefit, but we still have some room to go in fine-tuning that process. So what I have when I take a step back after all those years of working in the clinical consultative practice space, I think to myself, wouldn't it be great if we could have some sort of automated screening that didn't rely on providers and didn't require so much time to trigger what should be a more thorough assessment for people who are starting to experience shifts in their vulnerability. And this screening and monitoring could go directly to family or to the state programs, state and community programs that we have that are not necessarily connected to our healthcare system. And if those screening and monitoring tools could then trigger in-home resources or a response of some kind in a uniform way across these different sites. Can you guys still hear me? I think the internet just stopped.
Yes, we can hear you.
Okay, sorry. Everything went black in my computer there for a second. That these would trigger responses to the older adults who are most in need. So I'm going to pivot now and talk a little bit about screening for and monitoring frailty with technology. So when I first started my research, I was not in technology at all. In fact, I would probably consider myself a late adopter of technology, which in turn turned out to be a benefit because I feel like I represent more of our older adult users than young adult users. But accelerometry seemed like a really nice place to start, given so many of our frailty measures are reliant on mobility. This was particularly meaningful to me because it allows us to actually assess how people are moving in their free living environment and not in the 3 or 4 seconds that I'm assessing them walking down the hall of our clinic space. It also gives us multiple days of wear in the home setting and allows us to see some variability across the days of wear. It was fortunate that when I started this work, there were already quite a few older adult aging cohort studies that included accelerometry, so I had a lot of data resources to work with. What also is helpful about accelerometry is I think it provides different views of one's health. You can examine the accelerometry data in its very highest resolution format. That's 80 to 100 data points every second at a bird's eye view, and you can look at the wave-like patterns that one experiences over days of wear. You can also extract just a single minute of this data and start to see time that people are spending in vigorous activity, light activity, sedentary activity. On an even smaller scale, you're starting to see actual gait characteristics here, or periods where they're not moving and then transitioning to a standing period. And I would argue that even in a few seconds, we can start to see how people could perform certain functional tests. So this is an example of a thigh-worn device measuring a 3-meter usual walk, a thigh-worn device measuring a timed up and go, and a 5 repeated chair stand. So quite easily you can see the start and stop times there. When I first started this work, we had data from the NHANES. That was the first cohort study in the US to use accelerometers in their data collection. It was clear that there wasn't a whole lot of activity among the 60 plus group, and it wasn't clear whether this little bit of activity was going to provide enough heterogeneity for us to distinguish health status among older adults. So the first few years of my career was just trying to identify any concurrent validity of the accelerometry measures themselves and a variety of older adult health outcomes that you can see here. We also spent some time understanding kind of the implementation hurdles that we might have should we deploy these devices in a mass scale. We showed and studied the day of a week effects. Here you can see Sunday wear is significantly lower than other days of the week in older adults. We also showed in NHANES that the 7-day wear protocols can be particularly challenging for vulnerable older adults, especially those in minority status and with advanced age. And then we also studied whether shorter wear protocols over 2 or even 3 days were any different than 7-day wear. And you can see in this brief correlation that they actually mean activity was across the days of wear were very similar, whether we use 2 or 3 days of wear or 7 days of wear to calculate that. So once we kind of did those basic analyses looking at mostly mean activity and sedentary time, we wanted to start exploring how different patterns of activity might add to our understanding of both frail adults and also our ability to detect it in the community. At the time that I started exploring this, there was a publication by Dr. Jen Schrack that showed that with increasing age, activity tends to drop off after lunch. And this seemed to increase with increasing age. So we did a study that looked at the time of day, hourly activity, average hourly activity from wake up until sleep, and found that after you adjust for this afternoon shift in activity, the frailty status independently is associated with lower activity in the morning. And it really, we only needed those first few hours in the morning to differentiate frailty status. We also then went on to study the variability in the activity patterns across days of wear and in between individuals in a frailty status category. In this paper, we demonstrated that while frail adults have the lowest activity levels on average, they also have the most heterogeneous activity patterns across days of wear as a group, and that individuals that are frail also have very highly variant activity patterns across days of wear. They never follow the same patterns Monday, Tuesday, Wednesday, Thursday, Friday. So then we wondered whether those independent associations between frailty and activity mean and activity variance were independently related to changes over time in frailty. And so we pivoted to looking at predictive validity, which we don't have as much in the literature in accelerometry. So in this study, we took the same average hourly activity levels and constructed a within-person hourly activity variance across days of wear for each individual. And after adjusting for baseline frailty score, we use these variables to predict 2 outcomes. One was mortality in the first stage, and then in the second stage was change in frailty over time at 5 years among those people who survived. So one challenge, of course, with longitudinal frailty modeling is that people die when they're more frail and that the progression isn't linear. So we constructed a two-stage model allowing for these variables to predict death first and then then frailty. And what we saw is that the activity levels, the mean activity levels, and that within subject variability across days of wear were both independently predicted of mortality, and it was the variability in patterns across day of wear that predicted frailty decline at 5 years. When we adjusted for demographics and their health status, body mass index, and their cognition, it was just their activity, their mean activity volume that was most important for predicting mortality. And it was the variability across days of wear that was most important to differentiating people who went on to have worse frailty. So I think the work that I did, along with work from many, many other peoples that I've summarized in this slide, are showing that our activity patterns that we can collect from accelerometers are pretty complex, that they're saying more about an individual's health than just their activity level per se. And so here are all the people who have been involved in this space. It's definitely not just me, but we're making progress in that space. So knowing that the patterns themselves of the accelerometry are particularly meaningful to evaluating health, we decided to explore whether the patterns themselves were important in predicting cognition. So this was a study. I long have started to partner with individuals who have much more advanced analytic skills than me, because this is sort of beyond my scope. But this was a partnership with a computational scientist who does machine learning. We calculated 2 average activity levels, like a volume surrogate, and then calculated 98 different harmonic features. And what I mean by the harmonic features were, if you were to sort of spread out the accelerometry wear over 7 days and put the 24-hour segments back to back, you would be able to see the wave-like pattern of the day and night cycles. And the harmonics are describing the actual pattern shape. So 98 different features that describe the shape of that wave-like pattern. And what we did was test the relationship of these 100+ measures in predicting change in cognition among people who were cognitively normal. We used 2 different data sets. One was a local data set of my own, composed of predominantly minority older adults due to the location of the University of Chicago on the south side of Chicago, and using hip-based data with a 1-year follow-up. So super short time follow-up, hip location, and in a really high-risk, low-income neighborhood. We also tested the relationship in a nationally representative sample of older adults who were community dwelling. So the majority of them were Caucasian. They wore a wrist accelerometer, so a totally different location, for 3 days, and the follow-up period was 5 years. So super different group, super different follow-up, super different location. What we found when we look at the baseline Montreal cognitive assessment to the 1-year cognitive assessment, that the accelerometry measures, along with the demographics and health characteristics that we included, were able to differentiate those who had any decline, yes or no, on their MoCA at 1 year with about 83% accuracy. So not perfect, but better than a coin flip. And when we shortened the wear time to 3 days from 7 days, moved it to the wrist, extended that follow-up period, our ability to predict any decline in MoCA at 5 years went down to about 70% accuracy. What was potentially as interesting, or even more interesting, was the ranking of the predictive variables and their ability to their importance to predicting the outcome. And if you don't need to read any of these measures here, but you can see that age fell below the accelerometry measures for predicting or differentiating people who had any cognitive decline at baseline at 1 year, compared to these accelerometry measures. And this baseline MoCA performance itself fell way to the bottom of the list of importance to predicting the outcome. That was number 29 out of this list. So the accelerometry features here are the ones that are not labeled. So they were helpful in differentiating one-year follow-up in MoCA performance. In the national sample, the rankings were a little bit different. Baseline MoCA performance was the most predictive of or the most important to differentiating people who had change in cognition, followed by a laundry list of accelerometry features, their chronic disease, and then age and gender fell way below that. So you could see that the accelerometry patterns themselves were actually quite helpful in determining whether someone was going to have a decline in cognition or not. We are now trying to do something very similar using frailty as an outcome. In this case, we're expanding the number of accelerometry measures because we have a lot of data from other people in the literature that have identified at least cross-sectional associations between different accelerometry pattern features and frailty. So we are working on this now. This is all preliminary data, of course. It hasn't been published, but testing out different machine learning models to determine the one that will give us the best performance. We also have had some experience trying to remotely collect physical function tasks, some of which are important to frailty measurement, triggered by the pandemic. I'm part of the National Social Life, Health, and Aging Project, and during the pandemic, as many other cohort studies faced, they had to drop their in-person evaluation for much of their cohort. So we collectively designed a bio box and a bio booklet that walked individuals who were capable through their own biological, biospecimen, and physical function testing. We were only able to do this by adhering an accelerometer to the participant's thigh, which they did themselves. And as I showed earlier, we were able to pretty precisely measure their timed up and go and the 5 repeated chair stands without sacrificing that measure in the remote arm. And so it made it seem a little bit more practical that this could be done in a scalable way. So while I sort of spent a lot of my time working just on accelerometry and understanding how the mobility patterns themselves or the patterns of the entire 24-hour period are associated with frailty and predictive of frailty, we have a lot of other physiologic tests that can be collected using non-invasive sensors. And I think one space for future direction is how do we compile all these together to give us a better sense of one's overall well-being and physiologic integrity. So I'm going to pivot now to the second half of my research, and that is to talk about whether or not technology can assist with our frailty management. So just a quick, going back to our assessment and plan for frail adults in our clinical setting, you can see in the highlighted yellow here that much of our interventions that we use to reverse frailty core manifestations are exercise-based. However, being able to get a frail older adult to stay mobile, as I'm sure you can imagine and many of you have experienced, is quite difficult. Most of our frail patients are homebound. At least 1 in 5 in all community dwelling older adults are homebound. There's a larger racial predominance in multimorbid and low income group that are homebound and living in the community. This puts our frail adults heavily reliant on another human being to implement any of their care plans, let alone our care plans for their frailty. And most of our caregivers are not trained. They don't have any understanding of what's a safe exercise to do in the home. These are people who are giving up their time and volunteering. So it makes it very difficult. The dyad in frailty interventions is rarely the target intervention group. It's usually the patient themselves or an older adult as the target group. So we don't have a lot of literature on how we can best leverage and or utilize that caregiver to improve our management. And finally, older adults who are frail are more likely to engage in activity because of social reasons and not because of their physical function. So we don't leverage that social engagement aspect as much as we probably should in frailty management. A second reason why it's difficult to get long-term exercise-based management for frail adults in the US is that Medicare does not cover any long-term exercise programming. Most of the long-term programs that are offered come from the state level and funding that is trickled down from our federal government, from other funding sources. And these are often require low income status to be able to access those. So we have some coverage through community-based programs for our very low income, older, frail adults, and folks who are living at very high levels of income can often afford to pay for these services, but there's a really large segment of the older adult population, what we call the forgotten middle, that we just cannot get them great long-term care exercise programming in the community. We also, a third reason why it's difficult for frail adults to get engaged in exercise is based on their own challenges that they face to exercise behavior change. And I'm sure this will come as no surprise to any of you, but when we interviewed and surveyed older adults across different factors that influence exercise behavior change, driven, kind of modeled, or the framework for this was using the capability, opportunity, motivation, behavior change model. We found that frail adults had the most barriers, the fewest resources, the least likely to be aware of any programs. They had a very narrow window of exercises they were willing to do. They had really terrible self-efficacy for exercise, and their outcome expectations were exercise were also the worst. So, in terms of even getting someone to be able to engage in exercise or activity is very difficult when you get to be frail. We have also shown, and this is not my greatest area of research, but we have started to understand how the physiology in frail adults differs, and whether their energy availability itself or their response to exercise is the same across different states of frailty. And this was a study we did that showed that resting metabolic rate is higher among those who end up having more advanced frailty in a year. And so there's something that we don't yet understand about the disruption of metabolic physiology that's also impairing older adults who are frail from participating in exercise. So we produced a custom program to deliver exercise to a frail older adult in their home, a program that was delivered over a technology device. We specifically chose the voice-activated device with a screen, which is shown here, because end users told us they didn't want to use anything that required typing. So we pivoted to this mode to make it easier to access. We created this program using the NIA Go for Life exercise program, which is an evidence-based program with exercises that were intended to be done independently and in one's home. We also have a role for caregivers or care partners in the program to help keep them motivated and keep them safe. So in this program, there are two user groups. The older adult primarily engages with the voice-activated device. They're able to use their voice to activate the program. They're then walked through a daily routine with audio and visual instructions and a set of exercises targeting different muscles. The routines vary every day of the week, such that by the end of the week, they've hit all the major muscle groups. There's also kind of music to help keep them engaged. And then they rate how difficult that exercise was on exercise by exercise basis. And the program will auto adjust the intensity based on their report of the difficulty. So if it was too easy, then it will get harder. If it was too difficult, it will not progress or even back down. The care partners are able to access a portal, a patient portal on the web, and they can see an online calendar of the prescribed tasks for that day. As they're completed, they are checked off in real time. They are also sent messages that indicate whether whether an exercise was rated too difficult as a safety feature. And then they're able to use a messaging system, much like email, to go into the patient portal and send a positive message of encouragement that's read aloud on the older adult's device when they open the program the next time. So there's a bit of a social carrot to get back into the program. So we conducted this, we created and developed this program through a true participatory design method. It took us a long time to go through this back and forth process of getting feedback from older frail users to best co-design the project. But we successfully piloted this in the home, and now, as Olga mentioned, we're at the time of doing a randomized control efficacy trial. So this efficacy trial is based at our university, but we're recruiting from this really large geographic space in northeastern Illinois. Our goal is to recruit 124 older adult and care partner dyads. They function as a unit and are randomized together. Just a brief method, the older adults undergo a two-step screening stage for us to be able to isolate people who are frail. We are exclusively recruiting people who are frail, multimorbid, and homebound for this study. So there's a telephone pre-screen, and then our staff go into the home to do an additional in-person screen to make sure that we're isolating people who are specifically frail. They have to meet the Medicare criteria for homebound status, and they have to have a short physical performance battery of 4 to 9 to be eligible. The care partners are self-selected by the older adult as someone that they think is a meaningful relationship in their life, and they are randomized together into one of two arms. The intervention arm receives our Engage program on a voice-activated device. They have a 6-month opportunity to engage with the exercise program itself. And then we have evaluations at baseline 3 months and 6 months, plus a follow-up interview. The comparison arm here was very specifically selected to isolate the advantage of the mode of delivery to assist with exercise participation. So the older adults and care partners in the control arm also receive the voice-activated device. They just do not receive the Engage program on it. Then they receive a paper-based exercise handout, which is what I can do in clinic. So it's sort of mimicking usual care in that way. We have a very long, broad list of covariates that we're exploring. I'll just briefly mention, and then I would like to leave time for questions, but our recruitment for frail older adults has been a learning experience for me. I wanted to make sure that we really kind of put our money where our mouth was. That we've been advocating for including frail adults in trials across the years, and so I said we're going to definitely do this with this trial. Recruitment has been, challenging. We have randomized to date 63 dyads, but we had to just pre-screen 189 for that, and have done outreach to more than 6,000 people. So the pre-screen to randomization rate is about 3, and we're working on presenting the cost of recruiting frail adults to inform other people who might be interested in expanding to frail adults for their trials. This is our recruitment plan. As you can see, I was very optimistic that we would be able to recruit very quickly. We adapted that program and we're still behind. So we're doing our best, but it's been slow. Our most meaningful recruitment strategy has been to do in-person presentations at senior housing for anyone interested in pursuing frail older adult recruitment. And a little bit about our older adults. They have a pretty broad range of age. This is a predominance of women. We have a significant number who are low educated and have some cognitive impairment. This is very typical for the older adults who are residing in the Chicagoland and catchment area. We have a lot of multimorbidity, predominantly cardiovascular and musculoskeletal and metabolic issues, although depression is surprisingly very, very prevalent. Our care partner population so far is also somewhat surprisingly diverse. I was expecting a huge majority of people to be daughters. That is not the case. We have lots and lots of different kinds of people who our older adults are relying on every day and are self-selecting as meaningful relationships. So I'll just end by saying, all of the aging technology research I'm doing is just like a drop in the bucket. The landscape of aging technology interventions and monitoring and sensors is enormous, almost to the point of chaos. A lot of this stuff has not been adequately tested in trials, and yet this is all over the commercial landscape. So we have a lot of work to do if we are to appropriately select the kinds of programmings that will be meaningful to our patients. So I will stop now and hopefully have time for some questions yet. But I wanna put this slide about our implementation and scientific challenges back up in case it triggers questions and feedback. These are things that I'm still struggling to understand how to best overcome, and I would love to learn more from this group, get your insight and also suggestions. I think that was my last slide. Yeah, so maybe I'll leave this up, Olga, in case that's helpful. Oh, hang on, Olga, I can't hear you. Just a minute.
Yes. Thank you so
There we
much
go.
for your presentation. That was extremely interesting. Personally, I could have like a couple questions for every slide, but I'll let other people ask questions.
Sure.
Please add your questions, please, in the chat so we can move forward. While I'm waiting for the questions to come, I have some questions. I will start. How ready you think we are to use accelerometers in clinical practice?
Yeah, I was actually thinking about that as I putting these together. I mean, I don't think we're ready for prime time yet. But I think there's a couple of barriers. One, there's the research grade devices that give us high volume data, allow us to understand these patterns, allow us to tease apart the particular metrics that are most reflective of one's health status. And then there's commercial grade devices, which are highly scalable, but have less high resolution data. And that chasm, I think, is a real challenge. There are people who are using commercial grade devices like the Apple Watch and Fitbit and Samsung devices that can at least use some of their activity measures and the other things that they offer, like heart rate monitoring and oxygen saturation and body temperature and things like that. But we certainly haven't been able to translate the research grade findings to commercial grade findings yet. So I'm hopeful that the battery life will just get better on the commercial grade devices, and then we can just look at the higher resolution data.
Thank you. And there's a follow-up question to this. I think it's about funding. Like, how do you think we'll be able to fund this type of assessments or even interventions within clinics?
Yeah, so that's an interesting question. I don't know that I have a great answer for you, but I'll give you a couple of examples of things that we're doing already that are funding a lot of money. So in the US, Medicare, which is our primary payer, is already paying for an in-person visit called a Medicare Annual Wellness Visit. Older adults are getting them once a year. They come in for like an hour-long assessment. They get an evaluation that doesn't look too unlike what our frailty assessment does, which just pare down, and they're paying for this visit. So this is funding that is requiring an older adult to come into clinic for an extra visit outside of their regular routine doctor visit, and there's a reimbursement pathway for that. I would argue that if we could manage to move or translate some of these assessments or all of these assessments into a remote-based delivery, that the funding that's currently being used to pay for annual wellness visits could actually be used to help support the screening in the home and actually reduce the burden on patients. So it's not a perfect solution, but I think there's potential for this. We also would need to demonstrate, of course, that doing these assessments and monitoring for them over time are providing cost savings to the older adults' overall care. At least in the US, where our reimbursement is heavily weighted to reactive medical interventions like emergency visits and surgeries and procedures and not on preventive care, we probably have the most room to improve from ongoing monitoring and screening in the home. So that I would say that my hope is that this would be an insurance-based reimbursement, but we're not near that yet.
Thanks. There's a comment. Great presentation. What are the main challenges associated with using voice activation technology in frail older adults? Are there specific barriers related to cognitive impairment, hearing loss, speech clarity, or technological adaptability that limit its effectiveness?
Yeah, I think that's a good question. So just from a practical perspective, we did not expect any of our older adults to be able to set the device up. So there's a huge lift at the beginning of our study just to get the device set up and running. Once it's running, we have had very few technology support calls other than to have the accounts all repaired. So that was promising, I guess, in terms of the ability of the older adults engage with the device using their voice and having that not be a burden. The sensory problem is important. Um, in this particular intervention, we tried to use different communication modes to be able to get to both hearing and visual. So there's an audio recording. Alexa is walking the older adults through with speech. And then there's also a written and image on the screen, one of the reasons why we selected that big screen. So I do think that that will help. It's not, again, not a perfect solution, but hopefully that allows that minimizes the barriers that the sensory impairment contribute. It also doesn't, even though there is a touch screen on the device, it does not require the individual to touch anything on the device to get the program to work. So sensory neuropathies and other things like that are not interfering. Some of the other challenges, though, I'll tell you, even in 2025, 10% of our original participants did not have adequate Wi-Fi in their home in the city of Chicago to be able to run this very, very low, we actually tested as a super low Wi-Fi requirement to get the voice activated device to work. So we're providing hotspots, but it's almost unacceptable that that's still the case. So I think that is a challenge as well to using these. And then kind of a more interesting industry challenge is we've been working on developing this program since 2016. It's taken us this long just to do participatory design. And Amazon is cutting back on voice activated devices now because it wasn't the moneymaker that they anticipated. So we have all these other commercial based challenges that one can face, and I think is a bigger challenge to just getting interventions that we test from bench to bedside in general, where the landscape for technology is just changing every single day.
Yeah, great point. Another comment, very interesting talk. Have you considered splitting the assessment into 2 visits? I think they mean for the clinic visits that took 2 hours.
Yeah, that is a good, we have tried that. There, so what we've done is try to get these hour-and-a-half long assessment done, and then sometimes we'll save our more detailed assessment and planning conversations for the next visit, and that has allowed us to reduce the time to an hour and a half. In some cases, it's harder to split it into 2, especially for people who are coming to our evaluation for an elective procedure. There's a short time frame, usually 6 to 8 weeks, during which they're getting prepped for surgery and then they're going to go to surgery. So we need to know the risk assessment right away, and then we need to start the interventions right away. So there are some patients in which that works better than others, and certainly we've had to, you know, distribute those assessments over a couple of visits if someone is really, really complex.
Thanks. Are you able to get Go for Life via written pamphlets from NIA? They say that they used to get them during pandemic, sending out to veterans for exercise to do from home, but since then they have not been able to find a way to get these pamphlets.
Yeah, that's a really good question. So, when we first started the Go for Life, my favorite Go for Life handout, which is this little daily like flip book of exercises, they had that publicly available. We could make a request to have them print, 100 copies. They would send it to us. We'd hand them out for free. It was very, very accessible. The NIA has pared down their exercise programming. They have gotten rid of my favorite Workout to Go guide and have created, there's a booklet now. It's a little bit big, but it kind of walks people through like creating a calendar and some parts that are maybe a little bit too much for some of our frail patients or people with cognitive impairment. So I did save the PDF of the Go for Life handout. So now I just print them on my own in a color printer, and I'm happy to email that out. It's still my favorite handout.
Do you measure life space in your clinic and research patients?
That's a good question. The short answer is no. We have no questionnaire for life space, but I think it's really relevant to our patients.
Is there an association between self-reported activity and monitoring with accelerometry or other devices?
So there's actually, I was not doing this research, but there have been a lot of studies that have published this before. They are correlated, but at about the 0.3 correlation factor. So it is a statistically significant, but in general, the self-reporter are not doing a great job.
Some of the Google Apple Pod systems are offering some really great options. Also, enhancement in AI technology for low vision and blind services may also overlap to be a great resource. Just a comment
That's
there
a
for
great,
using
great
of AI.
suggestion. Thank
Yeah,
you for that.
yeah.
Thanks.
Someone's asking that you can share the the PDF of the workouts from
Oh
NIH
yeah,
and
for
also
sure. I can send them to you,
yeah, yeah,
Olga, or
the,
yeah.
yeah. They can contact us. They can get those. Yep, someone else said the same. Another comment. Congratulations for the interest presentation. On the a comment on the association of frailty and higher resting metabolic rate. It can be an association between frailty and accelerated aging. Can it be used like one future and usable biomarker for frailty aging?
Yeah, I appreciate that question too, and um, I feel like somebody else in the energy expenditure space probably needs to study this in more detail than me. So what was really interesting in that study, first of all, the population that we used was our local patient population. So we had about 140 or so older adults, predominantly African American, predominantly multimorbid, predominantly low income. So there's a great deal of stress, strain, frailty, multimorbidity in that group. In cross section, the resting metabolic rate was not associated with frailty after you adjusted for lean body mass. They're obviously very closely related, and it's the lean mass that's predominantly metabolically active. What was interesting is their resting metabolic rate after you adjusted for their baseline frailty status, higher resting metabolic rate predicted people who had frailty progression at 1 year. So I guess what I have always pictured in my head, not scientifically proven, of course, but just watching people progress through their frailty, is that their bodies are becoming very inefficient and likely utilizing more energy to maintain these somewhat rusty systems. And so I imagine that part of the reason that higher resting metabolic rate is predicting frailty decline over 1 year is that they're utilizing a lot of their free energy, and it's like preventing it from being available for other healthy things like exercise. So whether or not that's a biomarker that we use in the future is unclear. From a practical perspective, it's very hard to measure resting metabolic rate. You have to come in fasting after 12 hours. You have to, lay in a bed for 45 minutes and have some, either in a chamber or underneath it, indirect calorimeter hood. So that does not make it very practical for sure. Sorry, Olga, I'm having a hard time hearing you again.
Sorry, can you hear me now?
I can, yeah.
Okay, thank you. So I think we're now done with the questions, and I would say there's several comments on the chat about how great the presentation is, how very interesting it was. So thank you so much for presenting, and thank you everyone for participating in our presentation. So to inform the audience about our next presentation will be on Wednesday, March 12th at the same time, and it would be on primary care-led interventions for frailty, the Frail Merit Study by Dr. Pedro Abizanda from Spain. Thank you so much, everyone, and enjoy the rest of your day.
Thank
Thank you so much,
you.
Megan. Appreciate it.
Take care.